Good morning, friends. We are going to start the next session. I am Dr.Harbansh, and this session is basically on nucleus removal. I think if the nucleus was not there, we would have never needed the phaco machine. The rest of the material can be removed without that. So along with me, there is a galaxy of the speakers over here. Dr. Ashok Sharaf from Navasari, Dr. Rajiv Chaudhary from Indore, Dr. Anurag Mishra from Cuttack, Bhubaneswar, Dr. Rajesh Sinha from Delhi, Dr. Tinku Bali and Dr. A. Kedalal will be joining us shortly. So this instruction course is basically on practical pulse in the nucleus management during PHACOEMULSIFIcation and a clinical case scenarios in a different situations, how to handle the nucleus. So whenever we want to remove nucleus, there are certain things we need to understand before actually we start emulsifying. What are the anatomical facts of the eye and the nucleus? You need to understand your machine and a chopper, and you need to understand the removal techniques, steps and terminology of the nucleus removal. So if you see the nucleus anatomy, it is concave backwards. Why it is important? So that when you make a trench, it should be deep in the center as compared to the periphery. So make a trench according to the anatomy of the nucleus. And then there is a central safe zone. That means the area within the capsular axis and the pupil, there is a maximum space in the eye. Cornea is upwards and the capsule is backwards. So this is the area where all the phacoemulsification and aspiration should be performed. If you perform the phacoemulsification in the peripheral part, you are going to have a problem and a complication. So when we talk of the parameter settings, that depends upon what of the cornea it is, anterior chamber depth, pupil and iris, zonules, lens and a nucleus. So all these things, there is no standard set guidelines that these are the only parameters you should use. So depending upon the case to case, if the chamber is shallow, probably you need lower parameters. If the iris is floppy, you need lower parameters. If the patient is myopic, probably you need a less bottle height. So the parameter setting will be dynamic and depending upon the case. And also the setting will depend upon the type of the machine you have, whether you have got a third generation or fourth generation machine, and what experience you have, and what technique you are going to adopt, and which step of the surgery you are there. So when we talk of the vacuum, so vacuum is one which decides how much holding of the nucleus will be there. As we know, the force is vacuum into the area. That means if the tip size is 0.3 into 0.3 into 3.14 is 0.28. And if you make the tip size is just 0.45, the holding power becomes double. So that means wherever you need a very strong holding, you need a bigger opening. Like in a heart cataract, you need a regular tip instead of a micro tip. On the other hand, when you do irrigation aspiration, the tip size is very small, just 0.15, because you just need to suck it out. You don't have to really actually hold it. And the flow rate decides how fast the things will happen. Suppose you have placed at a vacuum at 500, how fast it will reach there and how fast the things will follow towards the tip is decided by the flow rate. So the vacuum decides the holding power and the flow rate decides the flow rate. So depending upon, again, if you are removing the things which you don't need holding, like you are removing the epinuclear plate, a lower vacuum setting will work, but you need a good flow rate. So the techniques are basically divide and conquer, chopping, stop and chop. And the steps are trenching, you make a trench, splitting, chopping and aspiration. These are the standard, whatever may be the technique. So this is what is the divide and conquer technique, where we make 2 trenches and then divide the nucleus into 4 pieces. So this disadvantage of this technique was more phaco energy needed, more time consuming, and pieces were little too large. So then came the stop and chop. Actually, stop and chop came after the chopping, because in this we make a trench, then stop doing the divide and conquer and go and chop the nuclear pieces. This is what is called a stop and chop technique. When we are talking of the chopping, we need to understand one term which we call as a vacuum seal. That means you bury the nucleus tip in tip of the phaco machine into the nucleus, build up the vacuum and hold the nucleus over there on the tip by creating a seal, vacuum seal over there, and then you can make a central chop. That means when you do not negotiate your chopper underneath the rexus margin, just at the center you vertically push the chopper down, it is called central chop. Peripheral or horizontal chop is when you negotiate your chopper underneath the rexus margin, go to the periphery of the nucleus and then start the chopping. Peripheral chop is much stronger as compared to the central chop, but at the same time there is a little more maneuvering is required. And then there is a modified peripheral chop. Instead of negotiating chopper to the periphery of the nucleus, you pull the periphery of the nucleus out of the rexus margin and start the chopping from the periphery. And then there is a direct chop. When you do not make any trench, just bury the nucleus with a high vacuum setting and start chopping. So when we do the vacuum seal, NUCLEUS at the central part of the nucleus give little bit of energy. Once the tip goes in, bring the foot pedal position to and hold over there. So when we do the peripheral chop or the horizontal chop, you can see my phaco tip is lying here. The chopper has gone to the periphery, and then we start the chopping from the periphery. I already explained what central chop is. Thank you for your attention. Now I don't see Dr. Ikeda is here. So she is not here. So I'll take up my talk.
You can continue with your next presentation, phacoemulsification in the heart cataract, till Ikeda will join us. Dr. Harbansh.
ये मेरे जो यहाँ पे स्क्रीन पे सब प्रेजेंटेशन रखे तो गायब हो गया है? क्या लग गया इसमें? इसको लगाने से प्रेजेंटेशन हट जाता है? चला दो इसको. So I'll be talking about the heart cataract now. Today, so this is a video with the voiceover.
How to operate heart cataract with average skill and excellent understanding of the biomechanics. While operating heart cataracts, certain anatomical facts are to be kept in mind. The central part of the nucleus is densest, thickest, and deepest. It is concave backwards, and most of these cataracts have posterior leathery plate. To manage these challenges, I am going to demonstrate my technique of V-trench, rotational separation, and radial split. For this, I will recommend using long and sharp chopper designed by my dear friend Dr. Mohan Rajan and Kelman tip for ease of trenching. Now I will explain what is V-trench. We make trench which is horizontally and vertically in the shape of V as shown in the diagram. Horizontally to accommodate the sleeve of the phaco tip, and vertically to reach to the depth of the central nucleus. Now watch the video. Peribulbar block has been given. Temporal limbal incision has been made. Capsulorhexis is being made larger nasally and on the left side. This is the area where most of the chopping, splitting and crushing of the nuclear fragment is going to take place. This prevents inadvertent damage to the capsulorhexis margin and prolapse of the nucleus into the anterior chamber. No hydro procedure has been done at this stage. This gives excellent stability of the nucleus for trenching. To make a pattern of V, start trenching paracentrally to have a wider trench at the periphery. The speed of the tip movement, energy delivered and depth sculpted should be such that there is no pushing of the nucleus and no cavitation bubble formation. If you are pushing the nucleus, that means energy delivered is less. If there is a cavitation bubble formation, that means energy delivered is much more than needed. Now sculpt more in the center to have vertical V trench. After withdrawing the chopper, we inject the viscoelastic and then withdraw the probe to prevent the shallowing of the anterior chamber. Now we will perform gentle hydrodissection before rotating the nucleus. Hydrodelineation is not needed. Keep the chopper at the periphery of the trench and rotate the nucleus. Now look how wide peripheral part accommodates the tip and sleeve comfortably to deepen the trench in the center. After adequate trenching, we split the nucleus. Nucleus has been divided into two parts, but posterior leathery plate is holding on. Now I will demonstrate my technique of rotational separation and radial split. Bury the phaco tip at the peripheral end of the heminucleus. Hold it firmly with high vacuum setting of 600 mm of mercury. Hold second heminucleus at the periphery with chopper and start rotating. You can see nice radial split taking place. Once it reaches the center, stop it. Now we will rotate the nucleus and repeat the rotational separation and radial split to divide the leathery plate into two. When you try to separate the leathery plate by lateral separation, you are trying to tear too many fibers in one go, requiring much higher force. Not holding the nucleus with the phaco tip makes it unstable and you put too much of pressure onto the posterior capsule and granules. While you use my technique of radial separation, you are holding and lifting the nucleus and there is no pressure on the capsule or granules. At the same time, using a radial split, you are tearing one fiber at a time, requiring much less energy. Now we come to second part of the surgery, what is called phaco aspiration. Hold the heminucleus deeper and at the densest part with high vacuum setting of 600 mm of mercury. Place the long and sharp chopper within the CCC margin adjacent to the tip. Bury it, move it laterally to split. Keep on repositioning the chopper closer to the fibers you want to split. Separated nuclear fragment should be as small as possible. They should be further broken mechanically by chopper. This improves the flowability of the fragment and prevents inadvertent damage to corneal endothelium. Use the combination of lateral and radial separation to tear the leathery fibers. Now we come to the removal of the second half of the nucleus. In this, I use modified peripheral chop, whereby I pull the periphery of the nucleus out of the rhexis margin and start the chopping. Combination of the lateral and rotational separation is used to break the leathery fibers. And nucleus is crushed mechanically and emulsified. Now most of the nucleus has been emulsified. We need to take extra precaution because the posterior capsule can move forward. Now we are going to remove our chopper. We inject viscoelastic to push the posterior capsule back. Reduce the vacuum setting to 500 and change the chopper from sharp and long to blunt and short. Now we have come to the removal of the last fragment, and this time posterior capsule and cornea, both of them are highly vulnerable. We lower the vacuum setting to 400 and use the chopper to keep the fragment in front of the tip and away from the cornea. That rhexis is larger nasally and onto the left hand side. Day 1 patient had absolutely clear cornea and 6/9 vision.
Thank you.
Thank you,
Harbansh. Now I'll invite Dr. Ashok Saraf for his talk on wide instrument cataract, primarily how to remove the nucleus in a wide instrument cataract.
Good morning, friends. At the outset, first of all, I thank All India Society for having me allowed to participate in this course, and of course the chief instructor, my friend, Dr. Harbansh, to allow me to share my views and my experience and how to do the phaco in wide intumescence cataract. The wide intumescence cataract is a morphological diagnosis where the cortex swells up, AC becomes a little shallow, and due to this, the intralenticular pressure in the bag, it goes a little high. And here the nucleus is not that very hard or like hypermature Morganian, but it occupies large area. Precautions, what you should take, there are in 2 stages. Number 1 is very important that you must debulk, means during the rhexis, you should be very careful, and during the phaco. So because of the high intralenticular pressure, there is an extension, fear of rhexis extension. So you must take precautions. Now this ND-YAG capsulotomy used to be in the past that people would do before 30 minutes and allow the fluid to escape from the lens space into the chamber, and then we'll continue. But now there are a lot of advantages and advancements that you make a puncture in the anterior capsule and allow the milky fluid to escape into the anterior chamber, or there is a very good technique by Mohan Rajan there where you used to have a 500 vacuum, put it in the particularly the venturi system, and put it on the anterior capsule, and with a thrust allow the fluid to be sucked into the probe. And what we have developed our technique. And there is another way that you can make a small rhexis initially, like orange peel, and then continue with the phaco. This is our technique. What we do here, you can see that. Actually, I'm holding the eye, and I'm holding the needle, and my assistant aspirates the fluid. You can see that. It has to be very, very controlled so that the rhexis doesn't enlarge. तो ठीक है. And once it is done, and then you can go ahead with the regular phaco surgery. Now, regarding the phaco procedure, we have to be very careful because there is hardly any peripheral cortex. There is almost no epinucleus. It is all what you come across is the nucleus. So no need for real good hydro. And routine phaco is enough. At times, you may need low parameters. But however, you have to be very careful to avoid PCR because there is no cushion. When you are phacoing the nucleus, usually we find the cushion of the epinucleus, but here hardly you find. Again, as mentioned earlier, it is very important to debulk the nucleus and see, you can see however, you have to be very careful. The rhexis maybe not be as you want it. But then once it is done, the fluid is, the lens is debulked and you can continue with the rhexis. And once it is completed, there is hardly any need for any hydro. You can rotate it. And as Dr. Harbansh has mentioned beautifully, you have to make a trench in the center. And you can see there is a sharp chopper. And then here, because the nucleus is not that very hard, of course, they're very soft too. So you have to be very careful, make a complete separation of the nucleus into two pieces, and then it is very important that you must hold it properly. And once you are holding it, and then you can really cut it. And then this is how you can emulsify the pieces. However, you have to take precaution and you have to be careful that the nucleus fragments, they don't go run around and damage the endothelium. You have to be very careful. Here you can see that the lens has already come into the anterior chamber. But again, there is no need. There is no need to, you can make into segments in the anterior chamber a little at the pupillary level. Again, as usual, it has to be debulked. Though this is making the rhexis is out of this course, but it is very, very important. Now here, see what you see, you can see that I have gone to the equator and cracked the nucleus. You can you have select your own way, but only thing you have to be very careful, make good segments, good fragments. And if possible, use a sharp chopper. And once it is cut, then it is easy. Again, you can use the parameters according to the consistency of the nucleus. You can modify, but the average or little low is enough. Again here, this is the orange fill technique. I'm going a little reverse way, making a small opening. And then you have to make sure that you go all the way down, make two halves. So it's very important to debulk the nucleus first, lower the intralenticulaire pressure, and then, according to the consistency of the cataract, you have to plan your phaco procedure. Thank you, sir. Thank you.
Thank you. Thank you, Dr. Shroff. Now I invite Dr. Ikeda to speak on soft cataract, and she can continue with the next posterior polar cataract.
A very good morning to all of you. I will be talking about phacoemulsification in soft cataract. So soft cataract, two steps that we need to keep in mind. One is rhexis, as it tends to run away since these are younger patients with elastic capsule. And secondly, the difficulties during phacoemulsification. As the cataract is soft, we end up operating on slightly lower vacuums, and this helps us in causing us difficulty in achieving a good vacuum seal and therefore chopping, which leads to formation of a bowl, and we tend to operate more in the peripheral zone, which increases the risk of posterior capsular rupture. So here the forceps help us in completing our rhexis if we find that we are not getting enough control with the cystitome. Now let's talk about the nucleus removal. In harder cataracts, since we use higher vacuum and the nucleus density is more, we end up achieving a good hold. Whereas in softer cataracts, because of operating at lower vacuums and as well as the nucleus being soft, it causes difficulty, and the epinucleus in these soft cataracts tends to be very sticky, and this makes it difficult for us to pull the nucleus towards the center to chop safely in the central safe zone. And therefore the tendency towards operating in the peripheral unsafe zone, since we try to get out of the sticky situation and pull up the nucleus. Now let's look at a few cases. This first patient here is actually a patient who is undergoing refractive lens exchange. So there is no cataract, it's a very soft lens. So here we managed to complete the rhexis with the cystitome. We have a good sized rhexis, so the technique that we use here in very soft cataracts where the rhexis size is adequate, say at least 5.5 millimeters, is just with the hydrodissection cannula, push the fluid wave till the time one of the poles of the nucleus prolapses up. And this makes it very easy for us to just emulsify the whole nucleus, as it is very difficult to chop since the nucleus is very, very soft, extremely soft in these cases. Now, if we find it difficult to remove this sub-incisional epinucleus and nucleus, we can pause, inject viscoelastic or dispersive OVD underneath it, and this will help us in prolapsing this soft nucleus up, and we hardly use any phaco energy in these cases. It is mainly vacuum, therefore very less chance of toxicity to the corneal endothelium, and we can safely emulsify these nucleus in the anterior chamber. Now let's look at another technique here. Again, I have a decent sized rhexis. So what I'm going to do is I am prolapsing slightly one of the poles up, but this patient has a small central nucleus as well. So a good hydrodissection and then a good hydrodelineation, followed by removal of this anterior epinucleus which sticks to the nucleus, gives us access to this small endonucleus that we have, and then we have just used the chopper to nudge up this endonucleus up and then just emulsify it with ease. So this is another technique. We can use our chopper once we have removed the anterior epinucleus to access the whole nucleus and emulsify it. And then we are going ahead now with the removal of the epinucleus plate over here and proceeding in the standard fashion. Now, another technique to use in soft cataracts, especially if the density is not that less or if we don't have a very good size of rhexis, is stop and chop, which is my go-to technique, especially for soft cataracts. So here again, we are removing this anterior epinucleus using mainly vacuum and no phaco energy. Here, rotate and remove the anterior epinucleus so that we have access to the nucleus a little bit more. And then the trench that we need to make here is not very wide. We need to make a slightly shallower trench, that we will narrower trench and shallower trench than we would make in hard cataracts. And then we can easily crack this into two heminuclei and proceed safely with stop and chop. The settings again that we'll use here, we'll use a moderate amount of vacuum. Do not operate on very low vacuums because that will make the fallibility of the fragments very less. Moderate amount of vacuum and low power settings are enough to deal with these kind of cases. So here we are just rotating the heminucleus and chopping the second part of the heminucleus. So this is another technique we can use, especially we are dealing with grade 1 to 2 nuclei which are not very soft. Now let's look at this case. Typically the difficulty that we face in these patients is we have a formation of a bowl. So this is what has happened here. I'm proceeding with stop and chop. I've managed to crack the nucleus to divide it into two heminuclei, and we have a good hydrodissection and a good hydrodelineation. But as soon as I try to grab this soft nucleus, it just cheese wires and I'm unable to get a good hold of the nucleus. So what we need to do when we are stuck in a situation like this, keep keep vacuum sufficiently high, a moderate amount of vacuum. I'm operating at 450, and keep the power very, very low, because if we have a high phaco energy getting delivered, we will keep cheese wiring the nucleus, and prolapse one of the poles up. So slowly and steadily apply vacuum to slightly anteriorly to one of the poles of the nucleus, and once we are able to get one of the poles up and a little part of the heminucleus we are able to grab it, the rest of the surgery becomes very, very easy. So if stuck with a position like this where we have a formation of bowl, then just slowly and steadily apply vacuum to slightly more anteriorly than we would in a normal patient of cataract surgery, and this is how we can come out of a situation like this. So to summarize, different techniques can be used for soft cataract, and different techniques have been described in literature as well. What works in our hands here is either we prolapse one of the poles of the nucleus with hydrodissection in extremely soft cataracts with an adequate size of rhexis, removing the anterior sticky epinucleus so that we have access to the nucleus. Either we can make a shallow trench, or we can emulsify the whole nucleus together. And if we have a formation of a bowl, use lower power, reduce the phaco energy setting that we are using, and use a moderate amount of vacuum to go ahead with the procedure. Thank you. So I will move on to the next talk now, which is on posterior polar cataracts. And here we'll just go through a video of a posterior polar cataract. This is a patient who has high hypermetropia, nuclear sclerosis, and pterygium. So this is the right eye of the patient. The pterygium is not affecting or causing a significant astigmatism. We can see here that the aqueous depth is adequate even though the patient has high hypermetropia, and the astigmatism is about 0.5 diopters. This patient basically required visual rehabilitation, and he was not concerned.
वीडियो नहीं चल रहा तुम्हारा?
Can we have the video, please? Sorry about that. I'll just try to play the video again. ये वीडियो कनेक्ट करना, पॉज करना एक सेकंड। All right, so the video is available, is visible now. So just to restart a little bit, this is a patient with high hypermetropia and pterygium, which is not causing a significant amount of astigmatism. The IOL power here is 36 diopters, and the aqueous depth is adequate at 3.03. So this patient desires only visual rehabilitation, so we are going ahead here with just the cataract surgery and not addressing the pterygium. So the rhexis size, when we talk about posterior polar cataract, should be adequate and not too large, so that we have enough sulcus support in case it's needed. Here what I like to do is use the technique of limited viscodissection, that is injecting small amounts of dispersive OVD just underneath the rhexis margin. This helps in preventing inadvertent hydrodissection during the time of hydrodelineation, because the dispersive viscoelastic provides a resistance and also helps in slightly cleaving the cortex for us. So this is what I typically do in all posterior polar cataracts. Now this patient has a stage 2 to 3 nuclear sclerosis. So here we are going ahead with creating a trench first. And what we need to remember during operating posterior polar cataracts is that we should avoid any undue stress to the posterior capsule. So what we have done, just gently crack the nucleus, and without aggressive rotation, we are just nudging the heminuclei and emulsifying it. So avoid aggressive rotation, just nudge from the side and prolapse the poles up to emulsify it. And another important aspect to remember here is, like I said, so we do limited viscodissection, never ever do hydrodissection in patients with posterior polar cataract. Before I come out and stop the infusion, always maintain the chamber stability, and I've injected dispersive viscoelastic. Now before removal of epinucleus, again something that typically I like to do in posterior polar cataracts is inject again a little bit of dispersive OVD under the epinucleus before removing it. This helps in removing the epinucleus as well because it prolapses it up a little bit, and also if we have had an inadvertent PCR, it kind of plugs that. Avoid too much over injection of OVD because that again can cause stress on the posterior capsule. If we have any fibers that are stuck on the posterior capsule, please resist the temptation to polish those, because just simple polishing in these patients can lead to a posterior capsular blowout, since these posterior capsules are extremely fragile. And in the end, we place a single piece IOL in the bag, and notice even during before coming out, I'm making sure that the chamber is stable and injecting an air bubble from the other side. Now this is the left eye of the same patient. This nucleus is slightly softer than the other eye, maybe grade 1 to 2. That was slightly harder in density. So I have changed my technique slightly over here. What we are doing is we are removing this anterior epinucleus again to gain access to the nucleus here. And as soon as I start trenching, the nucleus sort of starts coming up. So here we can just chop it because we have a small trench in the center that helps in just dividing this nucleus into two and then subsequently end up chopping it. So we need to remember that when we are operating posterior polar cataracts, the settings also need to be a little lower than what we would use for a normal case, slightly lower flow rate and slightly lower vacuum settings that we would use. And the energy we use can be decided on the basis of the density of the nucleus that we have. Now here, this is a case where we had a posterior capsular rupture, and let's see how we manage this patient. So we are going ahead with our standard technique, and this is again a soft cataract, as most of these tend to be since they present early in posterior polar cataract. And we are again taking all the precautions here, not aggressively rotating the nucleus, keeping the settings low, and proceeding with phacoemulsification as we would do in all patients with posterior polar cataract. So till now everything seems to look good, and I have emulsified the nucleus, and no inadvertent effect has happened. Notice that we are keeping the chamber stable. I have injected dispersive OVD from the side port before removing the infusion cannula. Now, as soon as we prolapse this whole anterior epinucleus plate, and once we remove the anterior epinucleus plate, I realize that there is a posterior capsular rupture. So we can see here superiorly that there's a posterior capsular rupture, and what we need to do is stay calm and make sure that we don't withdraw our phaco probe. Again, inject some dispersive OVD from the side port before we come out in order to avoid prolapse of vitreous into the anterior chamber. Then we are going ahead with anterior vitrectomy to ensure that there is no residual vitreous in the anterior chamber. And now, since we have a significant amount of cortex left, we have switched over to a bimanual irrigation aspiration instead of using the vitrectomy cutter, as it would be very difficult to remove all of this cortex, the residual cortex that we have, with the help of a vitrectomy cutter. So once we have ensured that we are not pulling on the vitreous and there is no vitreous in the anterior chamber, we can shift back to our bimanual, or if coaxial, whatever works well in your hands, irrigation aspiration cannula. And after removing this, this is the extent of PCR which is now visualized. We can see there's a significant degree of capsular dehiscence. So again, going ahead with vitrectomy, ensuring that we don't have any vitreous in the anterior chamber. We can use diluted triamcinolone if needed in these cases to visualize the vitreous better. And then here, because we had a decent sized PCR, we don't want to put the bag in the, we don't want to put the IOL in the sulcus, in the bag, and we have shifted to a 3-piece IOL in the sulcus. So in posterior polar cataracts, we must always keep a 3-piece IOL in our inventory, just in case we need to put an IOL in the sulcus. And we have to keep an IOL of suitable power, as we have to adjust the power of these lenses as well, since we are placing them in the sulcus. And then we use the vitrectomy cutter to remove all of the residual viscoelastic and seal the incision. I have injected some pilocarpine towards the end to ensure there is no vitreous in the anterior chamber. Thank you.
Thank you, Dr. Ikeda, for a wonderful presentation. Now I invite Dr. Anurag Mishra. He'll be talking about nucleus management in presence of a small pupil.
Thank you so much, Harbansh sir, for the kind opportunity. Good morning, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. the advent of new techniques and technologies, and of course the skill enhancements that we have incurred in the last decade or so, has actually converted this small pupil, which used to be a menace for us, into something very, very naive. And we are going to discuss how naive is naive and how small pupils have stopped to bother us altogether. Before going into that, what are the manifestations of a small pupil? The geometry is altered. It's become small. Due to the presence of several comorbid factors, the increased permeability happens of blood-aqueous barrier, and that causes an issue in the post-operative period. Particularly, you have to manage AC reactions more. There is a possibility of trauma to the tissues because the iris and the other tissues are closer to you. Small capsular opening, because it's a blind technique, you never know what's the adequate size of opening that you're making. Retained lens matter is very probable because the pupil is small and the iris can hide or clandestine small little particles of the nucleus as you're trying to emulsify them. And if you have a toric IOL to be placed, and 45% of our practice now is toric, so if you have a toric placement, then the alignment becomes difficult in the presence of a small pupil. Mechanisms in pseudoexfoliation syndrome, the dilator and sphincter muscles have a deposit in the stroma, and that causes an atrophy of these tissues. They don't respond to medications as normal iris does. In IFIS, there is a dilator muscle atrophy, and it causes a hypotony. In synechia or membranes, pupillary membranes, cyclitic membranes, they mechanically restrain and do not allow the pupil to dilate. We'll see how to handle that in a moment from now. Age-related, there is a generalized tissue atrophy that occurs everywhere, in the capsules of joints, to the brain, to the iris muscles as well. And in diabetes, you have metabolic changes occurring in the sarcomeres, which also prevent a pupillary dilatation properly. The resurrective measures, you have pharmacological agents, pre-operative NSAIDs, intraoperative agents, combination of different agents that work. But in select cases, if you have mechanical restraint or very, very rigid pupils, none of these pharmacological agents work. High molecular weight OVDs cause a mechanical dilatation, but that stays for a very short while. And if you can finish off your work before the pupil constricts again, fantastic. Otherwise, you have to continuously refill the AC. Cyclitic membrane, if it is there, it has to be peeled off. We'll see how to do that. And of course, the expander devices. And the last but not the least resurrection measure is not to use anything and try to manage the nucleus with that small pupil. Let's take up cases now. This is a patient who has got a long-standing history of uveitis. As you can see, the pupil's not even visible, and the cyclitic membrane is there all around. So it needs to be that there's a hole that needs to be punched first, and then with the Simcoe, it was extended. The moment the cyclitic membrane is peeled off successfully, you will have a little bit of bleeding from the pupillary margin. That, in fact, is an indicator that shows you that the pupillary membrane has been effectively removed. At times, removing these membranes just restores its geometry. It becomes more circular so that you can implant the devices. At some other points, however, peeling the pupillary membrane actually causes very effective dilatation. You might not need any device after that. So this is one such case wherein the pupillary membrane was removed, peeled off from the margin, and look at the way it dilates after that. So the mechanical restraint, the moment it's removed, it dilates very well in certain cases. So we should always try to do that. Coming to devices, this is an age-old device which a lot of times we had used in the past, but not anymore. I don't use it anymore at all. The iris hooks, because they cause an unpredictable tear in the sphincter pupillary muscle. So post-operatively, this pupil never, in fact, restored their geometry, and the sphincter function is essentially lost. Many people use a fifth hook subincisionally. I don't do that. But the important point here is it's a good idea to place all the hooks first into the AC and then try to engage the pupillary membrane one by one. That way, you will get your adequate size, and you would not overstretch any tissue, causing a tent in the peripheral portion. The Milligan ring is a 5-0 polypropylene, the go-to device, at least for me. The technique of injecting it is the distal scroll should be engaged first at the distal side. The side scrolls, if are engaged simultaneously while the ring is being engaged, it is fantastic, because then you have only one scroll left, which you can engage from the other side. And then after all the scrolls have been engaged, it has got an 8-point fixation, fantastic device indeed. And once they're all engaged, you can reshape the pupil and bring it back to the central point for your convenience. The Gupta's ring is an Indian counterpart of similar design. The only difference with this is you need a 2.8 millimeter section for this device to go in. It doesn't go through a 2.2. And then the other thing is, it has a joint in one of the flanges. You can see that on the left-hand side, and that joint sometimes just snaps open. So just have to be careful. And it's not as malleable as a Malugan, so engaging it is slightly more difficult, but it does the job and is more economical when the price point comes in. This is another Indian modification, our very own Shubenda. This is a B-hex, which gets in through a 9/0 nylon is the material out of which it is made. Very slender device, and you have to tuck alternate flanges underneath the iris. The only limitation this ring has is it does not work very well when the pupil is very rigid. So if the pupil is very rigid, you have to mechanically stretch it first and then apply the ring to get your adequate size of pupil. This is the Visitec eye ring, which has come up recently, and the material here is polyurethane, which is a much softer material. Just like the Malugan, it needs to be pulled into the plunger first, and then it has to be delivered into the anterior chamber. And then after it is delivered into the anterior chamber, one by one, all the angles can be engaged. The advantage that I found with this is that it maintains a more circular pupil than the other devices. So the shape of the pupil is more circular, and after its removal also the pupil somehow maintains its circularity. But finally, all that being discussed, the final thing is maintaining or managing the nucleus without any device. Because all these devices, since they stretch the pupil, the perfect geometry and the sphincter function, the aperture function is never restored to its normal capacity in the post-operative period. So whenever we can, we should be trying to manage the nucleus without attaching any device to it. Nothing much needs to change on the parameter front. As you can see, the IOP still is maintained at 20. There's a pretty hard nucleus. The pupil is small. You just need to understand that the business area is right at the center, and you don't need to go chasing the nuclear pieces, and they just come into you. There's an unedited video, and I just wanted to show you that it's not very difficult to manage the nuclei, even in the presence of soft nuclei, in the majority proportion of our cases. So whenever we can, we should. Thank you so much for the opportunity again.
Thank you, Dr. Anurag. Now it's my pleasure to invite Dr. Rajiv Chaudhary for his presentation on subluxury cataract.
Good morning, friends, and thanks to Dr. Harbansh for inviting me for this course. My topic is subluxated cataract. As we know, there is a surgical management of cataract associated with jonular dialysis. It's one of the difficult situations for the phaco surgeon, and it is a real challenge for the ophthalmic surgeon. There are multiple causes: traumatic, spontaneous, hereditary, systemic association. And management is varying comprehensive. Can I have the pointer? Yes. Comprehensive preoperative evaluation and assessing the area of weak jonular area and whether the vitreous is in the anterior chamber is there or not. So you can plan. So they are short in summary that if the area of zonular dialysis is 3 o'clock, 5 o'clock, 5 to 7 o'clock, so you can plan accordingly, whether it's at 5, 7, or more than that. So whether you want to CTR without CTR, or switching the CTR, or you have to go for glued IOL, or so basic is the incision should be away from the area of jonular weakness, the smallest possible incision. Capsular axis should be starting from begins in the area of remote from the dialysis, and should be ideal side 5.5 to 6, because you may have to put the lens on the capsular bag. And in case of external jonular weakness, it should be done by the blade, because with the forceps and sometimes you give more stretch on the jonules. Hydrodissection should be careful, nucleus freed maximally, parameter should be low, and divide and chop technique is preferred. Cortical viscodissection reduces the stress on the jonules. Manual aspiration is preferred sometime. Aim is to achieve the IOL centration and long-term stability. So there are some videos. It's a jonular dialysis is the less than 3 o'clock over where is some freeing of the capsule. So start away, then rexis. And once use the good viscoelastic, as is a hypermature cataract, Morganian, using the low parameter, avoid the turbulence in the anterior chamber. So it will not increase your dialysis. And we can finish the surgery, maintaining the good anterior chamber depth, using good viscoelastic because the turbulence should be avoided. Repeated injection of the viscoelastic. Keep your chamber inflated and put the lens haptics at the direction of the subluxation. So it will give S and it will avoid the decentration. If it is more than 5 o'clock hours, you can use the CTR. Just CTR can be placed before or after the bag, preferably before nucleus fragmentation. Then we can move on, and the management is easy. We'll go for another good video. This is extension more than 7 o'clock. We use the capsular hook. Try to do the rexis. One of the important point, use the good viscot, so avoid the fragmentation falling into the vitreous. Because the dialysis is much more, we tried to debulk the nucleus, but the turbulence was much more. So we used the capsular hook to stabilize the bag. 2 hooks. So once it stabilizes with the bag, your bag is stable, we can perform the rexis very well. Nucleus management with the low power, low parameters, so turbulence will be, skip. And once you remove this, you need the CTR. Suturing the CTR is must for these cases. We have to suture the CTR, the one area, and then put the lens and remove the bag. Now, in case of extremely loose, there is a multiple option of iris fixated, glues IOL, anti-chamber IOL. I will go for, we skip the glued IOL. This is the iris claw, the subluxated Morphin syndrome. Remove the lensectomy done. We'll skip. Okay. So I will show you the steps of the inclination. This is the important. Once you're done, friends, this is how simple it is to put the iris claw. Another main important is the holding of the iris claw from this point steady, because once you claw, it will give a pressure on the forceps, and once it is clawed, you can see a central. Another, the use of the femtocataract in doing the rexis. This is one of the advantage of the femtocataract. We can get a good rexis without creating any stress on the granules. Once you have done this, put the remove and suturing the CTR in the bag, fast formatting. And once you suture, you can put the lens. In short, this is the And one of the options, because the Amar is here, I want to show the gludiol is an option for managing the simple steps. Is one of the good option to give a 2 claw enclaved on this side and putting the lens into the scleral pockets, and this is the infusion created to maintain the chamber, and probably it is the well centered and stabilize the lenses. So in short, recent advances in equipment and instrumentation, better understanding of fluidics, give a relatively safe cataract surgery even in the subluxury cataracts. Thank you.
Thank you, Dr. Rajiv Chaudhary. Now I invite Dr. Rajesh Sinha. He'll be delivering his talk on NUCLEUS management in presence of corneal opacity.
Thank you, sir, for this opportunity. A very good morning to all of you. I'll be talking about NUCLEUS management in eyes with corneal opacity. See, the idea of the basic reason for presenting this topic is to understand, to discuss methods to enhance visualization, because in a case of a corneal haze or opacity, the visualization is an issue. So what is most important? It should be a well-dilated pupil, because if you have a central opacity and the pupil is not well-dilated, most of it will be covered by the opacity. If it's not dilating well, use hooks or rings to enlarge the pupil. Do it under peribulbar block, because many a times you handle the iris and the patient can have pain, and you can do it only if the opacity is partly covering the cornea. Trap and blue has been used for last almost, when I remember if it was in 97, 98 when it started, and for white cataracts to do the rexis it is used. But if you have a corneal haze or opacity, use it for a longer period. Why? Because it not only helps in doing the rexis, but it also helps you to see the capsular axis edge when you are chopping the nucleus, because of the corneal haze, it is difficult. Again, when you are doing a rexis, in such a case, when you are behind the opacity, don't leave the capsular flap. You leave the flap only in the area where the cornea is clear, so that you can hold it again and do the rexis completely nicely. And use of viscoelastic is very essential at every stage. You can do the chopping technique and keep your choppers, etc., in the area underneath the clear cornea, so that you can go ahead and complete the procedure. Once again, as you can see here, the capsular axis margin is still stained, so we can actually see the margin when we are chopping the nucleus. As I said, OVD inside the anterior chamber as well as over the cornea is very useful, because when you put a dispersive viscoelastic like methyl cellulose over the cornea, there is a sudden increase in visibility. And whenever you are doing a crucial step like chopping a nucleus, etc., in such a case, if you put a blob of viscoelastic like methyl cellulose on the cornea, it suddenly improves the visualization, and then you can go ahead and chop the nucleus nicely. As I said, good quality viscoelastic is very important. If you have a very hard cataract like this and you have a corneal opacity, if you have a corneal opacity, in such a case, if you keep doing the surgery, then it will be difficult to chop. So in such cases, even if the pupil is say 5 millimeters, wherein you can do the cataract surgery normally, easily, as Dr. Mishra was telling, it's better to enlarge the pupil in these cases so that you can see the area beyond the opacity. So use iris hooks or rings to enlarge the pupil. We have also done a study on a slightly eccentric crater, so that if the opacity is on one side partly covering the pupil, you can do a crater, create a crater on the other side, slightly eccentric. Can't go too periphery, because there you have the epinucleus. Another important thing which is very useful is the use of endo-illuminator, which improves the visualization in corneal opacities and haze. So when you are doing nuclear chopping, in such a case, you can ask your assistant to hold the endo-illuminator from outside so that you can do the chopping very nicely. And once you have completed the chopping, when you have to remove the epinuclear plate, it is better to take the endo-illuminator inside and see it carefully. So you take the as you can see now, the endo-illuminator is inside. You can exactly see the margin of the epinuclear plate. You can hold it and you can bring it towards the center and aspirate it completely nicely. And so that's how endo-illuminator again is a very useful tool. Only thing is that we have to understand how best we can use it. Chandelier illumination again is a useful tool in cases not with a leukomatous opacity, but in cases wherein you have a haze, a very bad ocular surface, or where there's a haze. You put chandelier illumination, you can get a red glow. Go ahead, do a rhexis, do nucleus chopping, etc., and complete the procedure. If you have a very bad opacity, in such a case, you can combine anterior lamellar keratoplasty along with the nucleus management. So if you, as you remove the superficial haze, you can see, as you remove the superficial haze, you can see the cornea clears up. And now, you can do any technique, whatever technique you want, go ahead, do a surgery, and then you can put corneal tissue depending upon the thickness of tissue that you have removed. If it is less than 200 microns, it can be left sutureless with glue at the edges, and if it's more than 200 microns, you have to put sutures. Something like this, a very bad one-eyed patient, another eye icicle. You don't want to do a triple procedure. In such a case, intraoperative OCT is giving you the idea that 80% of thickness is having the opacity. So in such a case, you dissect up to 80%, make it clear, leave a little bit of stroma, because if there is no stroma and a bare desmace, in such a case, doing a cataract surgery is very difficult. It can rupture the desmace. So go ahead and remove almost 90% of the opacity. And once you have done that, you can go ahead and complete the rhexis and the nuclear emulsification completely, and then of course you can put corneal tissue. So in conclusion, if we have an opacity or a haze in the cornea, the basic idea is to enhance visualization in order to do a cataract surgery. Trap and blue dye, use of dispersive viscoelastic on the surface. As I said, trap and blue dye for a longer period. OVD on the surface, endo-illuminator, chandelier illumination, all these things are very useful tool in making life easier for the phacosurgeon. Thank you very much.
Thank you, Dr. Rajesh Sinha, for really nicely elaborating all types of corneal opacity and the nuclear management. Now I invite Dr. Tinku Bali. She'll be talking about nucleus management in presence of PCR.
Hello, good morning everyone. It's my pleasure and privilege to be here this morning. And I'll be talking on the nucleus management in the presence of a posterior capsular rupture, and I'll be giving you more of a vitreoretina perspective since I'm a vitreoretina surgeon. Well, posterior capsular rupture is an unfortunate complication of cataract surgery and can have dire consequences. But if managed properly, the risk of complications can be minimized and the results can be as good as if it had never happened. The first thing is to anticipate a posterior capsular rupture in these type of cases, posterior polars, hard cataracts, post-traumatic cataracts, and you should be having a surgical strategy in your mind even before you start the case. Your staff should be briefed, your instrumentation should be ready, your vitrectomy machine, your cutter should be all in place so that you're not faced with a surprise when it happens. Recognition we all are familiar with is sudden deepening of the anterior chamber, non-rotation of the nucleus, loss of followability, tilting, and a bright glow. So the first thing is not to panic. Do not get overwhelmed with the situation. Instead, organize yourself and face the situation fair and square. Now, the management strategy would depend on the extent of the PCT, the intactness of the hyaloid face, the location of the nucleus, whether it's in the posterior chamber or in the anterior chamber, the availability of the equipment, the availability of IOLs, knowledge about a proper anterior vitrectomy, and the availability of a VR surgeon. When faced with a threat, we stop but do not retreat, and the same applies here. Do not panic and suddenly withdraw the phaco probe, because hypotony is the #1 enemy when this happens. So a PC tear does not equal an anterior hyaloid face rupture, and when you withdraw your phaco probe image, suddenly the anterior hyaloid ruptures and vitreous comes into the anterior chamber, as you see here in these pictures. So what you do is you stop. You see here PCT occurring. So whenever you see a PCT occurring, you stop. From the side port, you inject viscoelastic. A dispersive viscoelastic is preferable. When you have a stable chamber, a very well-inflated anterior chamber, that is the time you gradually withdraw your phaco probe. So you see here, no more vitreous comes in front. After that, the other important thing that you should know about is how to do a thorough anterior vitrectomy. Well, when you do vitrectomy, it should always be in a closed system, so always it's better if you can suture the main wound. A bimanual anterior vitrectomy should be done. Always remove the vitreous before you start tackling the lens fragments. Use a high cut rate, the highest cut rate that your machine supports, and a low vacuum. And in case you're using the machine that is built into your phaco machine, the vitrectomy system built into the phaco machine, then use the cut IA mode. So as you see here, the surgeon is using this main port to do a vitrectomy. You see how unstable the chamber it is. The more unstable your chamber is, the more vitreous keeps prolapsing forward. So this is not the way to do an anterior vitrectomy. Instead, make a side port, suture the main wound if possible, otherwise hydrate it, and then you see how stable the chamber is now when you're doing your anterior vitrectomy. When you do an anterior vitrectomy, the probe, the face of the probe should be facing forward. You should be keeping away from the margins of the anterior capsule so that you do not damage it inadvertently. Now, maneuvers like this, like using wax cells or using the scissor and pulling the vitreous and cutting, should not be done. You have to respect the vitreous base to prevent tears. So you see this kind of a maneuver where you're pulling and tugging on the vitreous can cause small tears here at the vitreous base, which could cause a retinal detachment subsequently, months or even years down the line. The plas planar approach to do an anterior vitrectomy is preferred by some and is of an advantage because it reduces the vitreoretinal traction and provides a better endpoint. You get better access to the remaining lens material and you're less likely to damage the anterior capsule. So it is not very difficult to master this technique. You have to make pars plana incisions. Your vitreoretinal colleague could help you out and teach you how to make these incisions. And this is how you go from the pars plana and do an anterior vitrectomy. Now, the nucleus management would depend on how much of the nucleus is left. So if there's a very small piece, you could even continue your phaco. You could get this nucleus into the anterior chamber, put a high viscosity viscoelastic, and then continue your phaco in the anterior chamber. You could enlarge the incision, convert to an ECC. You could use the chopstick maneuver where you use 2 instruments to get these nuclear fragments out. And in case there's a nucleus drop, then it's best left to the vitreoretina surgeon. Now, if soft lens matter is present in the anterior chamber, it should be carefully removed with the suction mode of the cutter before doing the anterior vitrectomy. So you can use your cutter itself to do the removal of this soft lens material. You use the suction mode. As you see here, it comes very easily with this cutter. Get it right into the center and then suck it. Now, a drop nucleus, as I mentioned, is a dire complication for the cataract surgeon, but it's a fairly straightforward problem for the vitreoretinal surgeon. So, drop nucleus cases, I always say, referred to a retina surgeon, fall into two categories, well managed and poorly managed by the anterior segment surgeon. So, this is something that has been repeated on and off. Don't chase after the falling nuclear fragment. Avoid unnecessary manipulations, and in order to avoid vitreous traction, retinal detachment or CME. The anterior segment surgeon should do a proper anterior vitrectomy and ensure there is no vitreous in the wound. And if the required instrumentation to do a good vitrectomy is not available, then it should be left for the posterior segment surgeon to do it. Retain a good capsular support. IOL placement should be done only if you feel it is stable, and an AC IOL should be avoided in case there's a nucleus drop. Tricot staining can be done in the anterior chamber to look for residual vitreous. The wound should be closed so that there's a non-leaky chamber for the posterior segment surgeon. Always have an arrangement for referral with a vitreoretinal colleague and establish the protocols for the initial management of the patient. The management of a drop nucleus can be done in the same sitting or it can be deferred. It's okay to operate within the first 2 weeks. So to conclude, do not panic and withdraw the probe when you have a PCT. Inject high molecular weight viscoelastic, reduce the bottle height, manage the nucleus appropriately, do a thorough bimanual anterior vitrectomy, place IOL and do not chase the nuclear fragments. Minimum intervention is the best option when you have a dropped nucleus, and a vitreoretinal consultation can often resolve a dropped nucleus with minimum morbidity and excellent visual outcomes. So PCR, if managed appropriately, can give very good results. Thank you.
I thank all the panelists and thank all of you for being here. And with this, we come to the end of this session. Thank you.